You guys hear me back there? Okay. Thank you very much for having me. I'm really honored and humbled to be here. First, I'd like to thank my co-investigators, especially Jeff and Lee down at the end of the table. Their experience in health services research is incredible, and they've really helped steer the course of this along the way. Jenna Cohen and Christina Koster are two graduate students in the School of Public Health whose objectivity and dedication to keeping this work forward has really been helpful, and they've got great careers ahead of themselves. The research we're about to talk about was funded by Robert Wood Johnson Foundation. We also received a lot of support from Mary Ann, Melissa Reba, Emily Ehrlich, and others at CHRT along the way, both giving their input into the research as well as administering the grant for us. As well as Blue Cross Blue Shield, David Scher, Linda Mackinson, Margaret Mason, Darlene Alreda, Rick Ward put collective input on this on a routine basis as we moved forward. In fact, nearly all the people I've mentioned, as well as Jean Malowin, met on a monthly basis over the last 2 years to guide this research and try to align it correctly with the Physician Group Incentive Program. The work we're about to report on stemmed from the results promoted in publication a year and a half ago in the Annals of Family Medicine regarding the first demonstration project on practice transformation to a PCMH, where they took 36 primary care sites that had gone to NCQA for PCMH certification and did 3 years of intense qualitative and mixed method reviews. And to summarize briefly, their report was change is hard. And it's really hard in primary care. There's limited adaptive reserve for change in primary care. There's not the infrastructure. There's not the right incentives. We're asking people to change who may not really know how to go about process improvement. And we need to learn a lot more from those people in the primary care settings about what they look at and how they face change in the patient-centered medical home world. So that's what we wanted to do. We did qualitative interviews in 16 primary care offices, asking the people in those offices and the leaders of their physician organizations about how they approach change and what they're looking at as they go for that. Today we'll report primarily on what factors are related to a primary care practice's readiness for PCMH transformation and start to peel back some of the approaches these groups are starting to use as they work forward on that PCMH journey. The selection of the sites, we used the 2009 Blue Cross PCMH self-assessment instrument that the clinics put into Blue Cross to identify where they were on that patient-centered medical home curve. Multiple domains and capabilities, we applied a scoring model to those responses and removed all practices that had not yet started the journey at all. So we at least wanted to talk to groups that were somewhere along that path. We stratified the remaining scores into quartiles and looked at the highest quartile, those with the furthest PCMH implementation, and those on the lowest end, but at least started it. We selected 4 sites with hospital affiliation and high scores, 4 sites without hospital affiliation and high scores, similarly on the lower end. The information we're going to present today, what we found had very little influence of hospital or no hospital relationship. Strong organizational input in relationships, but not specific to hospitals. So most of what you'll hear from us today is relation to those that are further along and those that are less far along at this time. We developed a 30-minute semi-structured interview guide asking questions about what got you started, why did you choose to do this, what barriers did you face, how did you overcome those barriers. As you look back, what might you have done differently, or what might you offer to practices that are just getting started on this journey? We concluded 66 interviews. The site selections were from various POs and throughout the state of Michigan. You can see physicians, nurses, medical assistants, practice managers, and leaders of 14 different physician organizations that were participating in PGIP. The research team created a code book of things we thought we might hear from those groups and went through all of those transcribed interviews and coded the responses. We then entered those coded interviews into an Atlas software system that allowed us now to start to pull codes related to areas of interest, and we're just starting that deep dive. Our initial focus here today will be on themes we're starting to see, especially related to an organization's readiness and the approaches they've been taking. Readiness, a critical precursor to complex change. Brian Weiner and colleagues last year did a very thorough literature review of organizational readiness and noted 2 primary dimensions of readiness. One being the motivation of the organization, their willingness and commitment to implement the change. As Weiner and colleagues stated, when groups face change, there's always uncertainty and uneasiness. So motivation is their perspective of trying to make sense of that uncertainty. We also looked at the capability of the organization, or the perception of those organizations in their capability to execute the change. Did they think they could do it? This is not the same as their capacity or the physical resource requirements that may be needed to move forward, but rather their perception. I have intentionally italicized that word perceived because all of the things you're about to hear now are the perspectives from the people being interviewed, from the level of altitude that they're at in their workplace and their work environment, on what they see and what they're thinking. I would encourage you to consider that all of those responses are correct. It's hard for us not to want to put them into a bad or good box, but hopefully if there's one thing you leave today with, it's a little kernel of how might we in the healthcare industry in support of this effort help provide perspectives that move this journey forward. One of the themes we identified under motivation was the perceived value of the patient-centered medical home. The key to success is getting everybody to focus on the patient. It truly needs to be patient-centered. For many years, I think we've been physician-centered, not patient-centered. For those that were further along, they had internalized the value of the patient-centered medical home. Well, we're doing this because this will be better for our patients, this will be better for us, this will be better for our physicians, and we might make some money along the way. That was pretty uniform in those that had progressed further, from the medical assistant to the nurse to the doc. Yep, we're doing this because this is good for us. Like those that were not as far along, they reflected that, really, we're already doing the patient-centered medical home. I think Diane stated that pediatrics started this stuff 40 years ago. But they also reflected that, but we can do this a lot better. We know there are still gaps in care. While we're doing this, we're already doing this, we can do it better. Compared that to those that were less far along that we also often got, I would bet you that almost every office has said, it's no different than what we've been doing. And there's nothing more to do. Or the requirements are merely checkboxes, an added burden of work to do, not fundamentally different in our practice. The perspective from these respondents often was, this is an externally imposed approach to something we need to change for insurance companies or for regulators. They had not yet intrinsically identified their value to their own clinics. Some reflected that, well, these are just more hoops to jump through to control costs, but not all of them. In fact, many of them, what they had heard, there was some interest, but they just hadn't gotten fully all the way there. Variable penetration in the practice, creating some organizational inertia there. Also, these clinics reported being pulled in multiple directions and were concerned that investing efforts in this change that may or may not work, that may or may not have the right financing, could actually interfere with their patient care, versus those that were further along who had said, this is going to be better for our patients. Finally, what's in it for my office? One of the leaders of a physician organization provided a concept of, to create change in their physician organization, they had to have a three-legged stool of improvements in patient care, improvements in the time for the physicians in the clinic, and or improvements in the revenue flow. And without at least two of those legs of the stool falls over and the sites won't keep going forward. And there were some of those reflections in those that had yet to progress. Understanding the patient-centered medical home requirements, what are the actual capabilities we need to do and how do we need to do them? I did all these webinars, TransferMed, MedFusion, all of them, to find out what I could get for PCMH. I'm sure my staff is sick to death of all these webinars, a practice manager, from a site that was far along in this. And those that were further along had, through their internalization, done some really active learning. Once they sort of got it themselves, they went out. They went to presentations in their health system, presentations by Blue Cross Blue Shield or other places, and really did some active, aggressive learning about what is this and how do we do it. A thorough understanding of the tasks that were needed to be done. Physician and practice manager were clearly the catalyst in these sites. One physician said, I didn't really do anything, but I came back and I said, I think this would be a really good thing, and people looked like I was from Mars. But now our practice manager has taken it and run with it, and we're really moving forward. The nuance of the progression in understanding the requirements and the influence of being stimulated by the perceived value is something we should consider. Those that had not progressed as well were more confused. You look at all these different measures, some of them are pretty difficult to understand. What in the world are they asking for, and what's the logic behind it? Many of these sites were interested in learning more, wanted to potentially go forward, but their interest in learning more was more passive. They wanted someone to come to them and help them learn. One of the respondents had said, we need the insurance companies to have better communication with us, and really they should come to our sites and teach us how to do this, but I know they don't have those kinds of resources. Interested but overwhelmed by daily work and the variable PCMH requirements, NCQA, PGIP, you've got priority and BCN messing around with some P4P stuff, and that confused them. Commitment to change as a third theme in motivation. There was a cultural aspect to some of the sites that had progressed more farther along, and that's just the way we do things here. We're always the first one to raise our hand and say we'll do it. This is a medical assistant of a clinic saying this. It had kind of transferred all the way down, and there was something about it that they were not fearful of change. They sort of looked at this with enthusiasm compared to trepidation. A near universal commitment to working on this change, and this is going to be fun. This is one more chance for us to work together on doing something different. Others struggled on the motivation, or at least it wasn't universal. I have 3 physicians who are not on the same page. It's hard to have a front desk staff that is doing things differently for each of the physicians. This uneven commitment did not mean they weren't interested or, in some respects, motivated to the change, but they couldn't quite pull it off yet because of the uneven commitment. We found, especially in the smaller independent practices, when the doctor tells me to do this, I'll do it. The reflection from staff, especially, that this is the physician's business enterprise. They own the business, and when they tell us what they tell us to do, we'll need to do that. A very honest and fair perspective, quite frankly. Financial incentives. The physicians are realizing, I'm doing more medical care, I'm doing less paperwork because I have more helpers, and I'm making more money. What's wrong with that picture? Let's peel this back for a second, because this was pretty consistent with the responses and the reflections of financial incentives, which is, first, the physicians are realizing, I'm doing more medical care, I'm able to do more for my patients. Second, I have more helpers, I'm doing less paperwork, our office flow is more efficient. And third is I'm making more money. The 3 legs of the stool, all 3 of them, but finances was mentioned last. And very often, most often in these interviews, financing was not the primary purpose for doing this. It was, we need to do this better for our patients and our workflow, and we need to make some more money. Several of these sites were starting to realize some of that revenue return from the pay for performance, from the T codes, from the increase in the physician group incentive payments, and many of them had begun to reinvest some of that revenue to get more support for data entry or care coordination or patient education. And they were really enthusiastic about that. That was sort of re-stimulating further motivation for them. Those that had yet to get fully engaged, they say we will get some more money for this, but I'll believe it when I see it. More skepticism. Is this really going to be sustained? Is this the new thing for today and it's going to be gone tomorrow, and you want us to do all this work that may interfere with our patient care and we may not get the money? And a very honest perspective of, gee, I don't know if we're ready to do this. Sticker shock in relation to that, especially smaller practices looking at the information technology components. Whew, big deep breaths for them. And they need more assurance of the return on investment relationship. And it may be that some of those sites are less internally capable of doing that evaluation. We may need some support for them in considering how the revenue enhancements, along with the workflow enhancements, can further motivate them. Now we're moving to capability, recalling that this is the clinic's perspective of, okay, can we actually do this stuff? Time demands, whether they're further along or less far along, that was identified by all, but a different perspective taken. From those that were further along, yeah, this is going to take us time, but we need to do this. We can't live the way we're living now. We need to do something different. Compared to those that we're still caught between a rock and a hard place, can't get off the hamster wheel, can't afford to take the time to get off the hamster wheel. The availability of internal resources had some potential influence or was coming out from these clinics. The clinics that were more engaged had sort of seemed to allow different people with different skill sets. Those that were good at IT take the IT. Those that like documentation, working on that. Those that were into care coordination or enhancing the patient, they could delegate some of those activities throughout their clinic team. Whereas those that were less far along, pretty consistently, the practice manager felt the burden of carrying the whole weight. I need to do this because my clinicians have to treat patients. I need to learn all about patient-centered medical home and teach my docs what this is all about. A different model and a perspective of approach. documentation was a huge influence on facing whether or not we can do this. Those that proceeded down the patient-centered medical home path felt that that documentation was required to identify further gaps in care. Those that weren't as far said it's just too much, and one respondent said, they want me to put too many things in too many different places. I wish they'd just have one place that I could put everything. I think maybe that helps or reflects back on this balance of we're already doing patient-centered medical home, but we can do better, or we're already doing it and there's nothing more to do. The documentation for those that proceeded more quickly reflected that that will help them identify gaps in care. Prospects of changing the patient behavior. The patient is at the center of this, but really how engaged are the patients? I don't know that we know that all that well, though those that were further along identified this as an opportunity to further engage their patients, a platform for us to talk about the accountability and responsibility that the patient must proceed with. Those that were less far along weren't sure they could impact the patient compliance, especially in our state where the socioeconomic environment has made it very challenging often for patients to comply. We could be doing all the right things in patient-centered medical home, but if the patient doesn't follow through, that would negate all of our efforts and aspects. And so that can intercede on their willingness to think they can actually get this done. Health information technology won't surprise any of us in this room. Huge expense, gigantic piece of PCMH. Higher percent, those further along in medical home had been able to leverage some of the support from their organization, whether it be a physician organization, a hospital, or otherwise, to learn more about the IT and get the right IT tools in there. And many of them were over the hump, I will say, with sort of getting data into the information technology resource and starting to see some value in it. So their skepticism or their belief in the capability was perhaps a little further along because they had gotten far enough along. Those that were less far along, again, the catch-22, the rock and a hard place, boy, you know, this HIT will be great. It will really help us reduce paperwork and increase workflow, but we can't afford it. We're not ready for it. We don't understand it. We can't move forward more quickly. And all of them reflected that the age of their membership in their clinic teams had an influence on their ability to use IT. Several of them were able to leverage the younger individuals who were less afraid of information technology to help them learn and implement and kind of mess around with it. Others struggled with those that were hesitant to get down there, and partly because of age. We had several older physicians say, it's not that I'm unwilling to do this, I'm just slower to learn how to do this. Setting implementation expectations. I've turned this one upside down a little bit where those that are less farther along, their perspective is this needs to be quick. One individual said, you know, I'll try this for a couple months. One physician had reported that the PO had supplied their clinic with e-prescribing instruments. They tried it for 2 weeks, and he decided that he liked writing the scripts by hand better. We had another clinic where actually the provider was really into the patient-centered medical home, the perceived value of it, but HIT needs to be much more quick for me, Chris, and I got probably 10 minutes of the iTouch, iPad potential and how that needs to relate to our EMRs and registries so you can just touch a button and have it all happen. Alternatively, thank you. We had 2 sites that I did in 2 weeks. One was a rural site, and the physician said, my wife's a minister. Hang on a second. He said, my wife's a minister, and I've been taught that every day I need to do things better. Every day we need to work on things better, and that's the way we need to do things in this clinic. The next week I was in a metropolitan large clinic associated with a health system, and the physician said a very similar thing. He said, the way we're going to get this done, Chris, is persistence, persistence, persistence. And then he said, do you have 79 seconds? And I said, sure. He said, I found this video on YouTube, and this is what I'm trying to tell my clinics we're going to go through. So,
with a note that read, wait.
IT.
Wasting her time, but she's too shy to put her best foot forward. Turned down by the Decca recording company who said, we don't like their sound, and guitar music is on the way out. A failed soldier, farmer, and real estate agent. At 38 years old, he went to work for his father as a handyman. Cut from the high school basketball team, he went home, locked himself in his room, and cried. The teacher told him he was too stupid to learn anything, that he should go into a field where he might succeed by virtue of his pleasant personality. Hired from a newspaper because he lacked imagination and had no original ideas. His fiancée died. He failed in business twice. He had a nervous breakdown, and he was defeated in 8 elections. exempt.
I apologize for the sound at all, but persistence, persistence, persistence. How about perspective, perspective, perspective? So now, quickly, I will go through a few of the approaches groups were starting to use. Translating the value of the patient-centered medical home, one physician organization had actually created a clinical advocacy team. Physicians who were visionary or actually believed in the value of the patient-centered medical home and could translate that value to their colleagues. Throughout those that had proceeded further in PCMH implementation, a common time to meet within the practice, once a week, once every other week, to reflect on what they were doing, why they were doing it, how they were doing it. Having those huddles was something we saw routinely. Translating the medical home steps into value, one thing that all reflected on was the assistance of a translator, often from the physician organization, many of whom we see at the quarterly PGIP meetings, the people that are closer perhaps to the insurance companies and the expectations, hearing from a lot of different practices about what they're doing, and helping the specific practices translate it into the action from their own sites. Several identified as well that we're going to celebrate the small successes. Incrementalism to a clinic, higher or further along this path, we need to do it one step at a time. This reduces our fear, prevents us from being overwhelmed. Let's learn about the medical home first. Several of the farther sites, or sites that were further along, had taken the NCQA and the PGIP and various other options, put them all together, and then put them on the table with their clinic and had the clinic say, here's where we're going to start. This is where the most value is to us. Using data. Those that were further along had an aggressive use of data. They wanted information. They wanted to identify gaps in care for their diabetes, asthmatics, etc. Those that were less further along also appreciated data, but they, again, were a little more passive. They got something from BCN, and boy, it would be nice if we got this from our other insurers. A call out that there are variable needs from these clinics. I think all of them will benefit from that data, but some want it internally and manage it internally. Others would like us from the environment to provide some of that information for them. Last slide. Those that have progressed further along also were dedicated to defining the roles and responsibilities of their clinic teams. This engaged and empowered everyone in the clinic. The staff especially really started to appreciate, wow, I've actually got a role. And I think that improved the efficiencies, or their reflections were that this improved efficiencies. No more 3 different ways to have to do it for 3 different docs kind of thing. Finally, adding sustainability to doing that. We interviewed one clinic that was part of 2 pods, and they said, we have limited staff, and so when someone calls in sick, the fact that we've got our roles and responsibilities written down and defined and we've discussed them all really helps us bring someone over from another pod. Leadership won't surprise you, but the combination of having the physician organization and or hospital leadership alongside the practice manager and physician to make this forward is a real catalyst equation, and including leadership supporting the time for the change. And finally, when asked, what would you do differently or what would you advise those that are just getting started, they all said, boy, we'd like to know what others are doing. We'd like to learn from others. Sorry for the rapid fire, and we'll turn this over to Dr. Green.
Thanks. I'm going to be kind of a segue between Chris's presentation of individual findings from what we've found here in Michigan and Jeff's discussion of the broader picture and the literature. So essentially what we found in this study both confirms and extends what was found in the National Demonstration Project. Our sample, though, was valuable to study because it is less highly selected. The NDP was a group of volunteers pretty carefully handpicked by the American Academy of Family Physicians. These practices that are participating in the PGIP program, these practices are practices like all the other practices around the state. They're somewhat volunteers, but much more representative. And so this suggests that the lessons really are more general. They're not specific to handpicked practices. Clearly, we found that the issue of resources are necessary but not sufficient. You got to have the dollars and the time, but that's not enough to move the practices that aren't moving. Adaptive reserve is critical. You've heard that term several times now. So what is adaptive reserve? Well, basically, there are several central elements, but 3 of the most important are relationship infrastructure, facilitative leadership, and teamwork. The adaptive reserve elements, and particularly these elements, the way people in the practice relate to one another, the way the physicians relate to one another. Are they 3 docs practicing alone together, or is it a group practice of 3? Those kinds of things. How the leadership interacts with the staff, whether people feel like they can bring ideas forward, all those sorts of things. Those differed pretty sharply between the high and low scoring practices in our sample. Somewhat in contrast to the NDP, we found that the office staff actually tended to be pretty gung-ho for this. It was the physicians that were often kind of the laggards and weren't necessarily on board. Now, the first thing that occurs to me in trying to interpret these results is, are these findings just predicting who's going to be successful in a PCMH transformation? Or does this actually tell us some news we can use? In other words, can we measure these variables and then say, oh, well, too bad for you, you're not going to make it? Or can we actually use this to guide some intervention that will help these practices along? And I think there are some stuff out there in the literature from the NDP and other things that Jeff will discuss that tell us that, at least in many cases, these kinds of variables can be intervened on. This practice can be saved, in other words. But oftentimes it takes some pretty intensive effort, some pretty intensive facilitation in the case of the NDP. They put a ton of work into changing these organizational variables, these leadership styles, these relationship infrastructures. It can be done, but the resources can be pretty significant and pretty intensive, and we have to think carefully about how we're going to arrange that, support it, and maybe how we're going to come up with ways to make it less difficult. So I'm going to stop there and turn it over to Jeff.